So we are going to deal something with a number of cases which we have done over here in our department and a little bit outside. So I think guided. So these are all the things which we started with. First was radiographic assessment, and then came CBCT, then came the guided implant softwares, navigation implant systems, 3D printing, and robotic surgeries. Now actually robotics is what in Japan and China is the talk of the town, and it will slowly come in and engulf a lot of people over here who are there in India also. But where we are standing is at the navigation implant system, which few of the colleges have. But mostly what we follow is this guided implant softwares. Why do you need guided? Because of the precision which it gives. It gives you a three-dimensional way of placing an implant with least amount of error. So this is what that system provides. If you see the older days, we used to take IOPA, we used to keep a GP point and measure and say, this is the height which is available. Worst come worst, what we used to do is to keep a cycle ball in the OPG and measure what is the amount of magnification which that ball has made, through which we will decide to reduce the bone quantity or the height. Then came the bone mapping. This was again one more different way of measuring bone width, the buccolingual width. So these are all the various systems which are there. Slowly, we knew that these were all two-dimensional. They were not three-dimensional. So things wanted to change. And that's when your history of CBCT started to come. Because in the X-ray, what looks like here as a halo band effect, which we think that it's going to fail. Most of the time, me and my HODs have an argument that this is an implant with an X-ray which is going to fail. But when you open up, you can see a good amount of osseointegrated implant. This happens, and this happens because of the X-ray beam which is getting diverted. So this is not a failing implant or a failed implant. This is an implant because the radiation, that thing is seen, which is called as a halo around effect, which we usually take it as peri-implantitis and which we scare, but this is not the truth. So as I said before, the cycle balls were the most important things which we used to think for diameter and then for placement. And based on that, we used to prepare a CD and then place the implants. Now things are changing. Your CBCT is what the one which gives you the clear-cut bucco-dimensional width and the height precisely. The CBCT not only helps in that, it gives you a beautiful anatomic landmark, which it shows. You can trace the nerve, you can trace the height of the sinus, residual crestal ridge, everything you can trace it within CBCT. And not only that, the technology is so improved now that when you go into these digital softwares, you can bring in your implants and put it down into the picture and say, this is where is my implant being placed. This is the height of the implant and the width of the implant. Three-dimensionally, we can measure. You can see the CBCT as in the lower DICOM files. You can see the implant being at the crest, and you have a good buccal and the lingual cortical plate. This is what your CBCT will give you. But will this give me the placement? Now I know how much width I have to place, how much of length I have to place. But if I have to place an implant, can I reproduce the same thing there inside the patient's mouth? That is still questionable, because what you are doing is a freehand drilling. So when you drill, not necessarily this position can form there. So that's why they started bringing in surgical guides to bring in 100% reproducibility. So these are the different cross sections with the CBCT. And this will tell you about how you are going to place. So after placement, the one previous picture, if you see the one which was there between the cortical plates, but after placement, when you see, you can see that your lingual cortical plate is under threshold. So buccally, you have left good amount of bone, but lingually, you are trying to hamper that area. But even though this is placed properly. So when you take these DICOM files which are there in the CBCT and you want to put it forward and you want to try to make a guide, I will show you a small video next about how this can be prepared. So these are different sections which will tell you width and the height of your CBCT. This is a video which I wanted to play for you. This is one of our cases. We wanted to first check out miss opposing tooth in the first quadrant, in the second quadrant, which was there in the upper molar area. So first we wanted to run around and check to see the bone dimension. So once we did that, we brought these DICOM files into a software, which will show me that these implants which I can place and check my position. So now I have placed an implant over here in the second quadrant. Wait, I will change the position. Yeah. Now I bring up the tooth structure. Next, I position my implant parallelly and bring it to the center. If I do this over here, I need to see this. Even after this, bone, it was not the same. See, sectionally, it was going mesially, and interproximally, it was not sitting in the correct place. So I had to adjust that with the tooth as well as the bone in that area. So this is what we did. And after that, this is called as a sleeve, the orange color which you're seeing there, creamy. So this sleeve is the one which will help us to make all these things are digital. They are there in the software. So then after that, I will try to mark the incisal regions, and then I will send it for a guide preparation. See this? This is your guide duplicate. This duplicates the stent. So once I have marked those incisal regions, this again will form into a guide which will interlock into the tooth and stay in position. Once I have done that, I will recheck whether the orientation is correct, whether the position is correct. Then I will give an entry for printing of the surgical guide. This one case, which I'll show you now, this was done after we did a graft socket preservation in that area. We preserved the socket with a bioactive glass. So once that was done, after 6 months, we placed those implants and we published them in as a continuous publication. One is one IJPRD, other one was an MDPI journal, which was a 3.70 impact factor. This was also done along with these protocols. This article is there available in the net. It's open access. This is the DO-Navy system. In this system, the abutments were also tightened using the shaft only. So we gave an immediate loading after the implant placement on the same day. This is 1 year follow-up check of how much bone loss was there pertaining to a control group and the test group where we did bioactive glass addition. So this is the advantage. These are few articles which will help you with meta-analysis saying that guided reduces the crestal bone loss, which happens initially, and improves the accuracy of your implant placement. These are few VDJ Nature journals which are there. This is one flow chart which will tell you when to use a fully guided system, when to use a partial guided system, when to you augment when you are simultaneously placing an implant, and what are all the key steps which are necessary to follow up. This is the future. That is your 3D impregnated implants. That is, you print your implant width and size based on the amount of bone which is available. This is one more 3D system which was there. See this? You can. This was a completely mandiblectomy case. They had tried to do a 3D crafted technique, which they removed. They want to see where the screw was and how much far the screw is going to engage your pterygoid process. So how much far it is going to get landed up over there or into your rest of the condyle, which is there evident over there. So this framework can be done completely using your 3D guided system. This is what will go into the patient's mouth. This was an partial mandiblectomy case, which was there. They were treating by the oral surgeons, which we could be a part of. So this is the accuracy which it gives. This is the implant Navi guide. I will show you this. What's the thing with this is, once you touch this and you go into this guide, you can see where your drill is coming onto the bone level. So you can adjust it based on a screen which it will be showing. So this is the next generation in which we are placing. See this? It will tell you in between the bone where you're going, and it will also tell you about how much of a depth you have gone back, how much of drill. So it will tell you when you are placing an implant, you don't need a guide, but this itself will act like a guide for you. This is your navigation system. There is one more system which is there available in the market now, which is robotic surgery. This is the last which I wanted to show you. See this? This was a case done in Yogi, which was in Japan. They tried to fabricate this part of the lost implant. This is still not into the market over here in India. They tried to see this. The computer was doing it. It was not the human. The computer, the robots were trying to drill in. The humans were assisting that robot. It was a hand which was going in straight. So it adjusted everything. And after the drill, you can see the drill itself, the osteotomy site itself shows you how the implant is going to go inside. It looked like a thread pattern. See, even the implant going inside is clearly visible. So this is future of dentistry and implantology.